This is the revenue cycle process presentation by Giavanna Pesci and Dominic D'Agostino. This is the revenue cycle. It allows for inpatient or outpatient hospital documentation made by a physician. Inpatient care is provided in a hospital where a patient goes through admissions and stays for at least one night. You are taken care of by nurses, doctors, and other health professionals, and outpatient care is provided in a hospital or a doctor's office, and you go home the same day. Patient registration, step 2. This process starts when providing information to hospital staff when the patient arrives for an appointment or treatment. Patient needs to fill out a patient registration form, including all of their information like their name, address, phone number, medical history, and their insurance information. This helps the hospital keep track of who the patient is and what they are here for. A beneficiary is someone who receives healthcare plan benefits. Health plans include Medicare and Medicaid. This means that they are entitled to receive medical services and have the cost partially or fully covered by the insurance provider. This can include medical expenses such as doctor's visits, hospital stays, prescription, medicine, and medical procedures. Primary versus secondary insurance. Primary insurance is a patient or a patient's guardian that can designate which insurance they choose as their primary or secondary insurance. Patients that are covered by their parent's insurance plan, the parent whose birthdays fall first in the year is the primary insurance holder. So, say your dad's birthday is in April and your mom's birthday is in September. Your dad would be the primary insurance holder because his birthday comes first. Secondary insurance is the patient who uses their parent's birthday that comes first. The second parent's birthday would be the secondary insurance. So, for the example I used for the primary insurance, your mom would be the secondary insurance. An accept assignment. This is when the provider accepts the full payment on the claim by the payer. This does not include co-payments and coinsurance amounts. A charge capture is step 3. A charge capture provides use of charge masters or encounter forms to select procedures or services that were provided by the patient. An encounter form is the financial record source used by the providers to select treated diagnosis and procedures or services provided during the encounter with the patients. It is also used when checking out a patient along with the medical record. A super bill and a charge master. The difference between a super bill and a charge master is that a super bill is where procedure codes are written and charges when completed during an office visit. A charge master is a term that hospitals use to describe a patient's encounter form. The super bill contains a list of common diagnoses and ICD-10-CM codes, procedures, and services. And it also includes CPT and HCPCS Level 2 codes. These are used in physician offices for billing. And a charge master is used for patient billing and medical coding for outpatients and physician offices, services, and procedures. Every healthcare organization creates a charge master to ensure accurate reporting of medical codes for reimbursement purposes. UB04 versus CMS 1500. UB04 claims for inpatient and outpatient services are submitted for reimbursement by the provider. These claims are only submitted in CMSC facilities, home health, rehabilitation, rural health clinics, hospitals, and nursing facilities. CMS 1500s is the opposite of the UBO4 claim. CMS 1500 claim contains special instructions for government programs. These claims are submitted electronically, but some providers have to submit them on paper. For example, dentists, because Medicare doesn't cover dental services, submitting a paper claim reduces the burden for dentists. Diagnostic and procedure coding and auditing. ICD-10 CM, or also known as International Classification of Diseases, 10th Revision Clinical Modification. These codes are reported for diagnoses no matter the health setting. Whether it's an office or a hospital, it doesn't matter. Assigned to diagnoses, conditions, and the symptoms documented. Reporting these codes are for services provided. ICD-10 PCS versus CPT codes. The International Classification of Diseases 10th Revision Procedure Coding System. These codes are only reported for hospital inpatient procedures. With these codes, there is an improvement to measure healthcare services, increased ability to conduct public surveys. They help improve research, designing payment systems, making clinical decisions, and a lot more. CPT codes, on the other hand, are level 1 of the Healthcare Common Procedure Coding Systems, also known as the HCPCS. These codes are reported for outpatient settings for medical services and procedures provided, as well as clinics, providers and offices, private homes, hospitals, nursing facilities, and hospital outpatient departments. The HCPCS Level 2, these are national codes. These include medical equipment, prosthetics, orthotics, and supplies. It is used to describe medical services and supplies that are not classified in the CPT codes. These codes begin with letters A through V, 5 characters long, and are followed by 4 numbers. They identify services provided by a physician and non-physician providers. They are organized by type, such as permanent national codes, miscellaneous, temporary codes, and modifiers. Patient discharge processing. Patient discharge processing begins when the patient information is verified, the patient is informed about discharge instructions, there is a follow-up that has been scheduled for later on, consent forms are viewed, and the policies are explained to the patient. Discharge planning is when a patient is informed about services after being discharged, for example, home care. Billing claims and processing. Patient information and codes are put into the billing system. CMS 1500 or UBO4 claims are submitted to third-party payers. A patient ledger. This is where financial transactions like charges, payments, write-offs, and transferred are posted to the patient's account so that they have access to this information. The claims submission and processing. This begins when the patient calls to schedule an appointment. The information on a claim includes patient insurance policy, identification, CPT, HCPCS Level 2 codes, and charges for procedures and services, and ICD-10 CM codes for diagnoses treated, and managed during the visit. There are some important questions that need to be answered in order for CMS 1500s to be submitted. Questions like if the condition is because of the patient's job, a car accident, insurance coverage, or use of an outside lab. If it has to do with the patient's job, then workers' comp has to be included in this process. Claims adjudication is when claims is compared to payer edits and the patient's health plan benefits to verify that information required is available to process the claim. The claim does not get duplicated. Payer rules and procedures need to be followed, and procedures performed and services are covered benefits. A clearinghouse. These use a secure network to receive and remit electronic transactions among payers, employees, and providers. When processing claims, a value-added network is important because it involves value-added vendors like banks, for example. They are more efficient and less expensive for providers to manage. They process claims in an electronic flat format, which converts CMS 1500 data to a standard form. Payment. When the adjudication process is finalized, the third-party payer decides whether or not the claim is approved for payment. When the remittance advice is sent to the provider, it is also sent to the patient and the benefits as well. This gets reviewed to make sure that there are no errors. Explanation of benefits. This is important for patients to look at because it will tell them if their claim has been paid or denied. These include patient information, details on service reported on the claim, benefit payment plan, and plan deductible summary. And the statement. Resubmitting claims. Claims denial versus claims rejection. There are times when the claim is denied because of an error and a correct one is made up for resubmission. If a claim is denied, it is because of a coding error, and missing information, or patient coverage issues. If the claim was denied because the service is not covered by the payer, the claim is rejected, and there is no chance for it to be resubmitted again. Denied or rejected claims are considered open claims until the appeal process for reconsidering payment is exhausted.
Hi, I'm Dominic and I will be covering the second half of this project. A third-party payer is an organization, public or private, that reimburses healthcare providers for the services they provide to the insurance enrollees/patients. This includes commercial insurance, including Blue Cross Blue Shield, as well as public government programs such as Medicare and Medicaid. The allowed charge is the maximum amount that the third-party payer will allow for a service or procedure. This amount varies from policy to policy depending on the policyholder's plan. Allowed charges will always be less than or equal to the fee submitted by the provider, ensuring that there is no overpayment. The amount that a third-party payer will reimburse is determined by the policyholder's deductible, copayment, as well as coinsurance. An assignment of benefits is a contractual agreement between a patient and a provider authorizing direct payment from the third-party payer. This happens automatically when patients visit an in-network provider. Without an assignment of benefits, it would be the responsibility of the patient to pay the medical provider first and then file a claim with their insurance company. An appeal letter can be submitted to reconsider payment for the procedure or service provided. It is used when claims are denied or there is an underpayment. It's important to process appeals as they are designed to recover lost revenue for the provider. Policyholders have a maximum of 180 days, or about 6 months, to file an appeal after learning about the denial. Technically, denied claims may be a result of errors in the payer's name or address. Clinically denied claims can result from incorrect codes being reported or not meeting medical necessity for services and procedures performed. Once submitted, insurers have 30 days to respond for a service that has not yet been provided and 60 days for a service that has already been received. An appeal is typically documented as a letter and signed by the provider with details explaining why the claim should be reconsidered. Documentation may need to be attached in order to prove medical necessity of the services and procedures. There are numerous reasons why an appeal may be submitted, including medical necessity, out-of-network provider, incomplete forms, as well as non-covered benefits. So, patient billing policies are set by the healthcare facility and are responsible for collecting payment directly from patients. These payments include deductibles, co-payments, and non-covered charges. A deductible is the amount a patient pays for healthcare services before their insurance plan begins to pay. After the deductible amount has been reached, patients will begin to share costs with their insurer via a co-payment or co-insurance. And higher deductible plans come with a lower premium cost, while lower deductible plans come with a higher premium cost. Self-pay customers are individuals who do not have health insurance or choose to pay for their care without using their insurance. The balance received from patients are posted to the appropriate accounts. These customers often receive a good faith estimate of how much their care will cost before receiving their care. Some facilities also may offer a small discount for self-pay customers. Now moving on to collections. Payment being sent to collections occurs when payment is not received from a patient in a timely manner. This results in letters being mailed to patients until the payment is received, and if the payment is still not received, the account will be turned over to an outside collections agency. So accounts receivable is the amount owed to the healthcare facility for the service, procedure, or goods provided. To improve the organization's accounts receivable, many facilities collect payments at the time care is provided to reduce the need for possible collection. And accounts payable is the amount that the healthcare facility owes creditors and suppliers. Many organizations adopt an accrual accounting method, which focuses on anticipated expenses that have not yet been paid. So, a past due account is an account that has not been paid by the patient or payer within a certain time frame, which typically may be around 120 days. Delinquent claims are claims that have not yet been paid by the payer/insurance company. Many providers tend to focus their internal recovery efforts on older delinquent accounts/claims of typically 120 days or older. So this may lead to an overlook of accounts in the earlier stage of delinquency, such as claims that are 30 days past due, 60 days, etc. And the delinquent claim cycle advances through aging periods based on the number of days past due. This may look like 30 days, 60 days, 90 days, 120 days, etc. And bad debt is an account receivable that cannot be collected by the provider or collection agency. In order for the provider to deduct the bad debt, the amount must have been previously included in the provider's income. Providers cannot deduct bad debts for money they expected to receive but did not. So moving on to the collections reimbursement posting. Once a collections payment is received from the patient/payer, it is posted to the appropriate accounts. And utilization management is a method of controlling healthcare costs and the quality of care by reviewing the efficiency and medical necessity of the care prior to and after the administration of care. Utilization management activities include pre-admission certification and review, as well as pre-authorization. Prospective care is a fixed rate of payment for service or procedure provided, and this is typically easier for providers and insurance companies to estimate costs and payments. And these savings from prospective care may be passed on to patients in the form of lower premiums and co-payments from their third-party payer. But the downside to this is that some providers might seek cost cutting measures to maximize their profit, whereas retrospective care is the final payment amount based on the actual charges, typically in the form of an itemized bill. This might allow patients to receive more attentive care based on their specific situation and the care that is required. But with that, providers may try to recommend costly treatments and services that may not have the exact medical necessity in order to maximize their revenue. A pre-admission review is a review for medical necessity and required level of care prior to the patient's admission. This typically involves insurance company pre-authorization, whereas a concurrent review is a review that takes place during the patient's stay for continued appropriateness of care and medical necessity of services and procedures. This is typically also the beginning step of the discharge planning process, and the review is in accordance with the intensity of service concepts. And pre-authorization, many insurance companies require pre-authorization for certain procedures and services. This gives the payer the opportunity to determine the medical necessity of a treatment or medication. And in certain situations, claims may be denied due to a lack of pre-authorization. Case management involves the development of patient care plans for the coordination and provision of care for complicated cases in a cost-effective manner. Case managers submit written confirmation to the provider authorizing treatment. Coordination of healthcare services in an effort to improve patient outcomes while considering any potential financial implications. Additionally, case management is often required as part of a managed care plan. And for example, a managed care plan may authorize a 24-hour home health care service instead of a hospital admission in order to save costs.